has the ability to detect these very microscopic shedding of tumor DNA, which no other modality can detect currently. So this is an example from one patient. This is a Foundation Medicine report. And you can see that each column is over time. There are 4 time points here, and there are 3 alterations listed on the bottom. This patient had ALK mutation. And you can see in the first 2 time points, no aberrations were detected. In the 3rd time point, MYC-N was detected again. But again, at that time point, there was no clinical imaging to corroborate disease. At the 4th time point, MYC-N was detected again, but this time the ALK mutation came back, and the scans at that time were still negative. Again, the patient was followed, and at the 5th time point, the VAF, the frequency, the number of mutant ALK went up, and at that time point, MFBG, which is not the topic of this talk, but probably a more sensitive imaging modality, was able to detect disease on imaging that correlated with the increase in the circulating tumor DNA. So this is just one example of many where we can use this to get a molecular minimal residual disease, a genetic signature of whether or not disease is still present before our clinical imaging can detect it. I'm going to highlight here 2 patients. I had the privilege of treating both these patients because each of these patients' stories illustrates another utility of ctDNA, how it can reflect disease status and also show us genetic heterogeneity. So if you look at patient 1 on the top line, this patient had both MYC-N amplification and an ALK mutation at diagnosis in 2017. She received standard high-risk therapy and unfortunately suffered severe complications, which limited her ability to receive maintenance therapy with antibody, but was in a clinical remission in September of 2018. When suddenly we did a liquid biopsy and we saw that the ALK variant had come back up again. And even though, again, she had no evidence of disease on imaging, we knew that meant that relapse was imminent. We treated her with lorlatinib, but we continued to follow the ctDNA, and we also noticed that the ctDNA, after a transient response, rose again, and she developed a new BRAF mutation, which we'll talk about why that's important in a few minutes. And unfortunately, at that point, she stopped having a response to lorlatinib, and she passed away in April of 2019. My second patient on the bottom level was also a little girl who had MYC-N amplification. And in her diagnostic tumor, we sequenced the diagnostic tumor tissue, and her tumor had an NRAS mutation. She received high-risk therapy and responded well, but unfortunately, after her surgery before transplant, we noticed her LDH was rising, and she suffered disease progression. We sent a liquid biopsy. That was the first time we sent a liquid biopsy, and the liquid biopsy showed the MYC-N amplification, showed the NRAS mutation that we knew about, but also showed us an ALK mutation. We had not seen this ALK mutation in the tumor tissue at diagnosis. This was new to us. We actually went back. We had frozen her plasma from diagnosis because we do that now on a lot of our protocols, which we'll talk about in a little. We went back to the blood from diagnosis to see if that ALK mutation was there, and it was. So it wasn't in the tissue, but there was another tumor site in her body that had that ALK mutation that had been shedding that ALK and contributed to her ultimate relapse. And so I think both these cases really illustrate to us the power of ctDNA, again, both to follow disease response, but also to show us the genetic heterogeneity that's present and contributing to disease progression. We've studied this in a systematic way to try and affect systematic change in 2 studies that I want to walk you through briefly now. The first study was led by Chris Bossi, and it's from our group, from Yael Moset's group at CHOP. And this was published in 2022. We sent over 150 samples from almost 50 patients with high-risk neuroblastoma at relapse to profile the ctDNA landscape. And I want to draw your attention to two findings in this figure. If you look at panel A, you can see that the blue, which are mutations that are unique to ctDNA, and the green, which are ones that are shared by both the tumor and the ctDNA. And you can see a lot of blue, meaning you can see that the majority are mutations that we only detect in the ctDNA, not in the tumor tissue. And if we ask ourselves, what are these mutations? Are they relevant? Are they important? Well, they are. If you look in panel B, you can see that a lot of these mutations are in the ALK and RAS-MAP kinase pathway. And this is important because these are potentially targetable mutations with targeted therapies that are available. The efficacy of these therapies we don't know yet, but there are targeted therapies available to these genetic alterations. We also showed, I'll direct your attention to panel B, again, like I've showed you previously, that the ctDNA levels rise while the patient is still in clinical remission before the imaging reflects disease progression. Okay, so you can see where the box that says clinical remission, the ctDNA VAF has already gone up while the imaging remains negative. And so we studied this within the context of a clinical trial, which is very important. This was the NAND phase 1/2b lorlatinib study, which I think a lot of you are familiar with. So in this study, this was a NAND trial where patients with ALK-driven relapsed refractory high-risk neuroblastoma were enrolled to receive lorlatinib, which is an ALK inhibitor, with or without chemotherapy. This was a very important study that demonstrated the efficacy and the safety of lorlatinib, but in addition, we collected serial plasma samples on these patients, and we did liquid biopsy with Foundation Medicine panels. And we used it to ask the question, what happens to the ALK mutation during therapy, and can we learn more about resistance by monitoring ctDNA? And we can. So in this figure, each column is a time point. Each kind of gray bar is a patient. And you can see that the ALK mutation comes and goes. And this was in correlation with the disease status. So patients had a detectable ALK mutation in liquid biopsy at enrollment. When they responded to therapy, that variant allele frequency, the detection of ALK, decreased. And unfortunately, if they progressed, the ALK went up again. But we also detected a whole bunch of other mutations that started coming up while the patient was on therapy. And we used this to identify two mechanisms of resistance. So we actually used this information to learn how patients with neuroblastoma become resistant to lorlatinib. And we found that in approximately 40% of cases, we could find that resistance with a new genetic mutation. So we identified two mechanisms. On the left, we identified new mutations in the RAS-MAP kinase pathway. So these are genes that are known to be very pro-survival genes. And I want to briefly talk you through patient 27 who starred there. So this patient at enrollment had two mutations detected in his ctDNA, an ALK mutation and an NF1 mutation. He also had two disease sites. He had a chest mass and he had a mass by his neck. He started lorlatinib, the chest mass disappeared, and unfortunately the neck mass kept growing. When we repeated the ctDNA, we found that the ALK mutation had disappeared, but the NF1 mutation had increased. And we actually single-site biopsied those tissue lesions, and we found that the chest mass only had the ALK mutation, and the neck mass only had the NF1 mutation. And so that explains why the patient had this pattern of response to therapy, and we were able to detect all this in the liquid biopsy. The second mechanism of resistance on the right side of the slide is that patients can acquire a second mutation in ALK. And so when they have two mutations in ALK, the lorlatinib cannot actually bind where it's supposed to, and it's not as effective. And we discovered this in the ctDNA, and then we took that back to the lab. We actually modeled that in cell lines and in computational modeling of protein and drug binding, and we proved that it was true. But we found all that just by following these ctDNA samples in patients on the study. And you can see here, this is a fish plot, so you can see here the ALK mutation 1174 was present from enrollment to disease progression. And at the last spot, the patient suddenly had a secondary ALK G1202R mutation that came up. So I want to spend just the last part of this talk talking about currently available assays, so drilling down a little bit to practically what this means for parents of children with neuroblastoma today. And then I want to show you a little bit about some future work, just 2 slides, about some future research work we're doing, because I think it's really exciting and important. Okay, so available platforms. How do we look at liquid biopsy? So this is not an exhaustive list, but these are the ones that are typically used nowadays. And this goes back to the different approaches that we talked about a little bit a while ago. So the easiest, I would say easiest, the cheapest, and cheap is important because these tests are very expensive and insurance doesn't cover them, is to do a probe-specific droplet digital PCR. If I know this patient has a specific ALK mutation, I can make a droplet digital PCR assay to follow that ALK mutation over time in my institution. So that I can do. The downside, obviously, is that we're only looking at that mutation. So if the patient evolves a secondary ALK mutation or an NRAS mutation, I'm not going to see it. But if I want to follow the burden of disease, that can be a very helpful, practical way to do that, and it's highly sensitive. Now, there are also commercial platforms available. These platforms are primarily driven by Foundation Medicine, who was really a pioneer in this field. Now there's also Garden 360 and Tempus. These are great panels, and they cover hundreds of genes. The downside of these panels is that they are designed to be broadly applicable across cancer, and most people in the world who have cancer are adults. And adult malignancies are driven by very different genetic alterations than pediatric tumors. So for example, Foundation Medicine reports MYC-N amplification. The other 2 do not, because MYC-N amplification is a hard thing to report on a sequencing panel. None of these panels reports deletions in ATRX, because again, it's hard to do that, and it's only relevant in neuroblastoma. So these panels are extremely important, and they've done a lot of pioneering work in the field, but depending on the patient and depending on the specific genetic alterations in that patient, they may or may not be very useful, depending on the question you're asking. And so to address this gap, we developed a neuroblastoma-specific liquid biopsy panel. The technician who works with me is going to be presenting it tomorrow here at A&R. And I'll just spend a minute talking about that. We picked 23 genes that are recurrently mutated and relevant to neuroblastoma, and we designed this panel to target these genes exhaustively. Top, bottom, the entire gene, except for TERT and FGFR, because we really only see specific mutations there. And therefore, in these genes, we can detect mutations, small deletions, small amplifications, any kind of alteration, but only in these genes. And so again, there's advantages and disadvantages to all these approaches. We developed this in the research lab, but it was very important to us to move this to patient care. So we partnered with the Division of Genomic Diagnostics at CHOP, and we made this a CLIA-CAP certified tool, which means any patient across the world, and we send them from across the world, can send in blood to get this test done and get clinically validated results that are returned to the clinician. I just included some brief data. This test was certified in February 24, so through February 25, 186 tests have been run at CHOP, and almost 40% of them have had abnormal results, which was somewhat shocking to me. That's a very high number for this test. And so this test is being utilized, and patients are deriving benefit from sending this. The practical aspect of this is that because the panel is so small, we were able to cut costs significantly, but we'll talk a little more about the logistics of that, I'm sure, in the questions. So to finish up, the current studies in neuroblastoma are all collecting plasma samples for liquid biopsy. So in ANBL 1531, which is the COG study looking at the addition of lorlatinib for patients with ALK-driven disease, we are still collecting ctDNA. On the rest of 1531, they've collected it serially throughout treatment, and there's a presentation on the preliminary data from that at A&R. In Europe, on HRNBL2, we are collecting serial samples. And the goal of these samples is to do retrospective analysis, meaning the data aren't being done in real time. These samples will be sequenced, and then we will look and see what mutations, what findings correlated with outcome. If a patient had positive MYC-N at end induction, did that matter before transplant? Did it not? We don't know the answers to these questions. The goal of this is to answer those questions. There are also precision medicine trials that are happening in relapsed neuroblastoma. So on the European side, there's the Mona Lisa, which I'm sure some of you have heard about. The purpose of the Mona Lisa is to take relapsed patients in Europe, and they will be randomized. Some of them will have they will all have plasma drawn, but some of them will have results returned to the clinicians to see how those results affect decision-making and ultimately, hopefully, improve patient outcomes. And the goal of this study is really to show that liquid biopsy is essential so that we can get EMA and FDA approval so that it can ultimately be covered by insurance. So this is, even though logistically you would ask, why do this study? It's actually quite important. And there's also the MIGHTY study, which is going to be a transatlantic collaboration within the NANT, where any patient enrolled on a NANT study will have liquid biopsies drawn, and we will return those results to the clinicians in real time. So the patients on those studies will have those results given back to them. Practically speaking, there are different approaches in clinical practice. Some physicians are able to use these to detect minimal residual disease. And I think what's become fairly common at this point, certainly in my practice, is any patient who relapses, we send a liquid biopsy from that patient at relapse to learn if the tumor has changed genetically and if that will affect our therapy choices. 2 quick slides on some future directions. What I've shown you till now has all been looking at the DNA, so looking at mutations in the DNA. But I'm going to take you back to my first slide. There was a lot of gray there, right? 50% of patients don't have targetable mutations in their neuroblastoma. And right now, we have nothing that we can do to profile their tumor, and that needs to change. So some research that my team is working on, among others, so some people are looking at ChIP-seq. We don't have time to get into that, but I wanted to just briefly show you this. We can do Oxford nanopore sequencing, which is whole genome sequencing that also looks at DNA methylation. And we can detect tumor-specific methylation marks in the cell-free DNA, which mimic the tumor. And these are agnostic of mutation. These are methylation marks that signal there's neuroblastoma. And so we want to work to develop this as a marker that can be utilized for patients who don't have MYC-N or ALK or NRAS or something else that we can follow in the DNA. And my colleagues there are the ones who are pioneering this technology. So I wanted to leave some time for questions, so I'll end now. I want to thank my lab at the Children's Hospital of Philadelphia. I want to thank the CHOP Center for Applied Genomics, my collaborators. I specifically want to highlight grant support from the Evan Foundation. Wendy is here. The Evan Foundation has been instrumental in funding the progress we've made on liquid biopsy. Specifically, the CHOP neuroblastoma panel has really all come from their generous funding. And in addition to the monetary support, I personally want to say that every time I have a meeting with Gavin and Wendy, I leave inspired to do better. So thank you for that. And my other funding sources are listed there. And I want to also thank, of course, our patients and their families for providing us with these gifts of patient samples that we can use to hopefully help other children. I'm happy to take questions.
Thank you, Dr. Berko. Does anyone have any questions? No one? Okay, yeah, we got a couple.
So I think that's a really difficult question.
Can you repeat the question?
Oh,
The
sure.
microphone was off.
Sure. So the question was, and you can correct me if I say this incorrectly, that some parents now are requesting ctDNA or getting ctDNA with clinical scans. Do I recommend that or not? So I think that's a really complicated question, and I want to acknowledge the nuance of practical realities. The scientist in me says, of course, let's get it at every time point possible. And information is power. We can wrestle with what to do with the results, and sometimes it's not going to be easy to make that decision. Like, what happens if you have detectable MIC end at end of induction? Nobody knows. Does that mean you shouldn't go to transplant? You should get chemoimmunotherapy? Does that mean you should? We don't know. We will know in 5 years, but that doesn't help the patient in front of me today. So I think, so the scientist in me says, yes, absolutely. I know that insurance doesn't cover these tests, and parents are paying out of pocket, and we're talking about thousands of dollars that people don't have. So how do we deal with that? What do we do with that information? So I can tell you that in my practice, I send the ctDNA at time points where that information will impact my decision making. And then I'm working to develop these patient-specific droplet digital PCR probes that I can use to follow the patient at scans. So I'm doing that right now. I have a patient at the end of chemoimmuno. It's a little unclear what to do. We're going to look at her ALK and her MIC-N, and that will inform our decision making. I know that's not really an answer, and I'm not trying to shy away from it. I just think that's the practicalities on the ground. Parents, we don't have thousands of dollars to, we use a lot of charitable organizations to help us cover it, but we don't have that kind of funding. And hopefully that's something that we can maybe together use, push for. But it's a problem in adult cancers too. Adult cancers face the same problem. Adult patients are also in the same boat.
Okay. And then a question, like if the child is not a patient at CHOP, but you want to do CHOP's ctDNA, how would somebody go about doing that?
Yes, so you absolutely can. I should have put the QR code here. I can send Pat the information, and she can perhaps distribute it. I send samples from Israel all the time. Samples are coming from the UK, from across the US. Again, it depends what question you're asking, but the advantage of the CHOP panel, it's about half the cost. And it gives you information that you need.
My question is actually kind of a follow-up to that. How to bring awareness to maybe smaller hospitals that aren't aware of this technology? Is there a best practice? Is there a way that those? I'm not sure they know it exists. I'm not sure they know what to do with it once they order it and all that stuff.
Yeah, all right. Thank you for that question. It's an important one. So I think a couple things. So I think, again, the use of ctDNA in neuroblastoma, that the onus is on us to publish more. So I think that these two studies that I demonstrated have really kind of set the stage. We need to publish more of our findings to show how it's important. We're also working on a paper specifically on the CHOP panel, which hopefully will be submitted in the summer. We're talking about it here. We try to reach out through parent forums, but again, I unfortunately don't have a great answer because it's not yet incorporated into standard clinical practice. And that leap, which again is true of adult malignancies too, but that leap will happen when I think it becomes part of the protocol. So now again, if you're on a study, we're taking the samples and we're putting them in a freezer. But when we're returning those results in real time, that will be the change. I think that's happening in the relapse setting, patients with relapse disease, that's already happening, but it's not happening for upfront patients yet.
Okay, another question?
Yes, thank you for all this information. Our home hospital recommended that we did a saliva swab for types of future possible cancers that my daughter could get. Can you explain the difference between a cheek swab and then this is all just plasma? So, I mean, is there a difference? Is the cheek swab useless? Is it?
These are all
Just curious.
No, these are all great, important questions. A cheek swab, I would assume, is germline DNA. So, right, we have to remember, we have our regular DNA in all of our bodies, and then we have our tumor DNA, and they're different things. So our tumor has mutations that are not present in the rest of our body. So oftentimes a diagnosis, depending on the tumor, depending on the findings of the tumor, or sometimes in standard practice, we will also look at germline DNA to make sure, let's say if we have an ALK mutation, that it's not germline, because that has implications for the rest of the family, for future, for a lot of things. But that's not looking at the tumor. That's just looking at the rest of the body. So that's actually why we separate. So when we separate the blood, we have the red cells, we have the white cells in the buffy coat, and we have the plasma. The white cells are the body DNA, and the plasma has these pieces of DNA that are shed only from the tumor. So different. And we need to be careful because we sometimes pick up in the plasma all kinds of things that are coming from normal tissue. These are present in very small amounts, and we have to be very careful what conclusions we make from that.
Else, we're all done? Okay, thank you, Dr. Berko.
Thank you for having me.